Hello and welcome to this Dovetail snippet on HRT Basics. My name is Ashley and I am a practice nurse, so I will see patients for HRT initiation and review. I wanted to put this together so that we have a sort of a basic guide to some of the common issues that we may come across. Some of the things we need to be aware of, and absolutely when we should be referring. So we'll cover symptoms of falling estrogen levels, diagnosis of menopause or perimenopause, contraindications for hormone replacement therapy, and hormone replacement therapy treatment options. So, symptoms of reducing estrogen levels can present as night sweats, hot flushes, sleep issues, vaginal dryness, mood changes, myalgia, so joint aches and pains, urinary issues, changes in libido, and cognitive changes. So, how would we diagnose the menopause? So, if we first think that menopause is defined as somebody who is over a year since their last menstrual period, and we have somebody presenting over 45 years of age with potentially a history of menopausal symptoms, then we can diagnose menopause or perimenopause. Some key things to think about is that we do not need a blood test to diagnose the menopause. We should absolutely be investigating any abnormal bleeding first. And if we don't have a classic presentation, thinking about a differential diagnosis, if there could be any other cause for some of the symptoms that your patient is presenting with. At present, the guidance is if somebody is presenting with potential menopausal symptoms under the age of 45, then we would arrange an FSH blood test. The guidance from NICE at the minute is that we would have two results over 30 when taken 4 to 8 weeks apart to confirm a diagnosis. So some contraindications for HRT, which I think this is absolutely important for us to be aware of. Breast cancer, current or historic, undiagnosed vaginal bleeding, current or past VTE or thrombophilia disorder or a family history of that, uncontrolled hypertension, untreated endometrial hyperplasia, liver disease with deranged LFTs. So, venous thromboembolism, when we're thinking about those risks, thrombophilic disorder, also known as thrombophilias, are conditions where the blood has an increased tendency to clot, potentially leading to unwanted blood clots, thromboses, in blood vessels. These clots can cause issues like deep vein thrombosis, so DVT, or pulmonary embolisms. While many individuals with thrombophilia never experience symptoms, others may develop painful clots that can be painful, swollen, or even life-threatening. Endometrial hyperplasia is a condition where the lining of the uterus, the endometrium, becomes abnormally thick. This condition is generally caused by an imbalance of hormones, specifically an excess of estrogen, which stimulates the growth of the uterine lining. Well, this is not cancer. It can increase the risk of developing endometrial cancer if left untreated. And the most common symptom is abnormal vaginal bleeding, such as heavy periods, bleeding between periods, or postmenopausal bleeding. Now, with any of these conditions, we can obviously refer to a specialist for advice, and that may not necessarily just be a gynecologist. We can also discuss with our oncology teams if a patient has breast cancer or a history of breast cancer. We can ask for advice from those specialties and absolutely refer to menopause-specific clinics or gynecology if needed. So, Estrogen-only HRT. Now, when we look at what causes the symptoms, it is a reduction in estrogen is what will lead to symptoms experienced by women. However, giving estrogen without progesterone to women who have not had a hysterectomy will significantly increase the risk of endometrial cancer. So estrogen-only HRT should be carefully assessed and only offered to those who truly do not require progesterone. So unopposed estrogen should only be used in those with a total hysterectomy with no endometrial tissue remaining. If somebody has had a subtotal hysterectomy, then we need to establish whether they have any remaining endometrial tissue. And so in this case, a sequential regime can be trialed for 3 months. If the patient experiences any bleeding during that 3-month time, then we can say that we feel they do have some endometrial tissue remaining, and then we would continue with continuous combined HRT. If there is no bleeding, then we can safely say that they only require estrogen, as they would have no endometrial tissue remaining. So for subtotal hysterectomies, that is something really important to consider when deciding what preparation and what regime we're going to be discussing with these patients. Sequential HRT. So this would be for a perimenopausal woman, which would be defined by it being less than 12 months since their last menstrual period. They would have daily estrogen with progesterone to trigger a bleed. The progesterone should be prescribed for 12 to 14 days of the month. Any regimes that use progesterone for less than 10 days of the month are seen to increase endometrial cancer risk to 3 times that of baseline after just 6 months of use. And so we should not be using a 10-day progesterone regime. We should be using a 12 to 14-day progesterone regime. We should be swapping to combined after 5 years of starting HRT or by the age of 54, whichever comes first. For women who would like a bleed-free regime, we can trial a continuous regime after 12 to 18 months on sequential if they wish to try a bleed-free regime. However, some women will still have some fluctuating estrogen and progesterone levels naturally, and so they may get some unscheduled bleeding if we change to continuous too soon for them. And then we can try it if they wish. And the risk of endometrial cancer rises with sequential use after 5 years. For the first 5 years, there is little difference to baseline. However, after 5 years, the risk is around 3 times baseline. So you might think, why would we ever use sequential? So sequential is for perimenopausal women who have what I would sort of refer to as maybe a background cycling. So they're still having some cyclic bleeding. This could be irregular because their ovarian hormone production is a little bit varied, if you like. If we were to put them straight onto a continuous regime, they would have unscheduled bleeding. And so sequential will regiment their bleeding. But we should absolutely be moving onto a continuous combined regime after 5 years or by age 54, whichever comes first. As we've said, if they really want to try a bleed-free regime, then after 12 to 18 months on sequential, they can try continuous if they wanted to, but with careful discussion. So continuous HRT for postmenopausal women, and that is defined as it has been more than 12 months since their last menstrual period. We can also use combined continuous HRT if they are not having a period due to the use of hormonal contraception, or because of post-endometrial ablation, they're not having bleeds. So this would be daily estrogen and progestogen. Everybody should be moved onto continuous combined after 5 years of HRT or by age 54, whichever comes first, provided they have a uterus, provided they need that progesterone element, or as we've just said, if they've had a subtotal hysterectomy and we can evidence that they do have remaining endometrial tissue. So, preparations of HRT. We have oral, and when we're thinking about this, we're not specifically thinking about your oral progesterones. We'd be thinking about your oral estrogens or combined estrogen and progesterone. So this is a cheap option. Some patients like it from a compliance point of view. They like to take a tablet. However, there are slightly higher CVA risks, and so it should be avoided in those with a migraine with or without aura. So any history of migraines, we wouldn't be using oral HRT. Again, we're not thinking about just progesterone. We're not thinking about like micronized progesterone there. We're thinking about the oral estrogen element or combined estrogen progesterone. We then have transdermal, so we're thinking patches and gels there, which again may need to be used in conjunction with progesterone separately. We've got a lower CVA risk, so preferred if we've got migraines, we're overweight or over 60 years old. So if we've got more risk factors there, we'd opt for transdermal. We have vaginal estrogen. We can use that if there's more urogenital symptoms. Now, if we're only using vaginal estrogen, then we wouldn't need to think about progesterone if there's no other element of HRT involved. If we're just using vaginal estrogen for somebody who has recurrent UTIs potentially, and there's no other reason for that, or they've got significant vaginal dryness, etc. So purely urogenital symptoms, and we're just using vaginal estrogen, we wouldn't need to offer progesterone as well. We have the intrauterine system, so the coil, hormone releasing coil, which would provide the progesterone element of HRT. The only option that is the recommended progesterone dose for all strengths of estrogen component, so can be useful there. And there's also tibolone, which can be used as an oral alternative to HRT. When we think about some of the alternatives, we now have some guidance on complementary therapies. So CBT, cognitive behaviour therapy, has been newly recommended by NICE for management of the menopause, as well as hypnosis, yoga and mindfulness. There have been some studies on these being almost as effective as some hormone replacement therapy treatments. So it can be something that you can discuss with your patients and signpost them to some information about that. Supplemental and herbal remedies do have less evidence base behind them, and so we should always be recommending that they're using an MHRA stamped product to ensure safety. Alternative medications that we can consider are SSRI and SNRI medications. So while NICE doesn't recommend them blanketly as first line, they can be useful in some situations. Some things to consider is that we would potentially think about paroxetine unless women were taking tamoxifen. Venlafaxine can be used for women who are taking tamoxifen. And citalopram, fluoxetine and escitalopram have also been shown to be effective in reducing those vasomotor symptoms. We would avoid fluoxetine and paroxetine in women who are taking tamoxifen, and that is because it can reduce the efficacy of tamoxifen. It would be considered off license for those with breast cancer if they're not taking tamoxifen. However, I would always advocate for discussing that with oncology before initiating. In fact, anybody with any current or historic breast cancer, I would be having a discussion with their team before initiating any treatment plans. We do have to think quite carefully about endometriosis if we are offering HRT. So if HRT is given too soon after a hysterectomy, it may not always give enough time for that endometrial tissue to regress. So I would always consult with secondary care on an appropriate time interval for HRT after a hysterectomy for endometriosis. There is a potential for reactivation of endometrial tissue located outside of the uterus, which could cause symptoms. And that's because it's thought that estrogen could contribute to malignant changes of any remaining endometrial tissue. However, we do have some studies that have suggested that the dose of estrogen isn't enough to stimulate endometriosis. However, because there's a risk, I'd always want to have advice from the gynae team. Perimenopausal women who have surgery should be prescribed tibolone or combined HRT until the age of natural menopause. Again, I'd want some plan from gynae. Postmenopausal women can use HRT, but should avoid estrogen-only HRT. Again, the risks should be discussed and assessed, and absolutely worth seeking specialist opinion on this. Breast cancer. Now, there's been lots of research. We've had some conflicting advice in the past, but NICE continues to advise that HRT increases a risk of developing breast cancer for women. Continuous HRT has the higher breast cancer risk than sequential. So if we think back to a few slides previously, where we said that if a patient wanted to try a bleed-free regime, they could change from sequential to continuous after 12 to 18 months. I would be wanting to have the conversation with that patient that continuous HRT has a higher breast cancer risk than sequential, and really making sure that they understand that their choice and are making an informed decision if they wanted to try an earlier combined continuous regime. The risk of breast cancer is lower with estrogen-only HRT. However, because of the risk of endometrial cancer, that's not an option if the patient has a uterus or a subtotal hysterectomy where we've evidenced that there is remaining endometrial tissue. Or, as we've just said, for certain cases where patients have had endometriosis. So we do need to think very carefully, as always, about estrogen only. So the risk rises the longer we're using HRT. It does drop when it's ceased, but it could potentially still be elevated from baseline 10 years after HRT use. Anybody who has a family history, we should be thinking lifestyle and non-hormonal options first line. If symptoms are very severe, then again, we can refer for specialist advice and HRT may be considered. Current, past or suspected breast cancer is a contraindication for HRT. So if we are referring any patients with breast lumps, we would need to halt their HRT until we understand the pathology of that lump. Estradiol levels. So the NICE guidance is very clear that it is not considered reliable enough to form part of diagnosis, dose adjustment, treatment plans, etc. These levels can vary depending on an individual's metabolism and many other factors. Estradiol levels should not be used to determine the severity of symptoms of menopause. Treatment should be based on the symptoms and aiming to control those symptoms. When we are presented with bleeding issues on HRT, firstly, we should be arranging investigations for those with more than 3 months history of intramenstrual bleeding, persistent irregular bleeding, infrequent heavy bleeding if they are obese or have a history of polycystic ovary syndrome, any postcoital bleeding, any bleeding that occurs over a year after their last menstrual period. So any post-menopausal bleed should be investigated, and any heavy bleeding with additional symptoms such as pain or pressure should be investigated. When we have completed those investigations, then it's worth thinking about compliance and addressing any issues to compliance, potentially considering an IUS, so a coil, as we can see greater bleed control with that. Potentially reducing the estrogen dose, as if the estrogen dose is too high, then this can cause some bleeding issues. Thinking about, would an alternative progesterone be more tolerated and control the bleed better? So sometimes changing the type of progesterone will gain bleed control. If it is safe, we could consider an oral estrogen preparation. So that could either be oral estrogen or oral combined estrogen progesterone. And we're saying is it safe because if we remember, those are the types that have higher CVA risk factors. So if it's safe to, we could consider an oral option, as they do have slightly lower bleeding risks than the transdermal preparations. We could potentially consider adding progesterone in, additionally, if they are on a combined preparation. So a short 3-month additional progesterone if on a combined preparation. And again, we could be referring on for advice on this. I would absolutely be referring on for advice on off-license vaginal route of administration for micronized progesterone. That's not something that I would initiate, but we could refer on for advice on that off-license use. The British Menopause Society has some really good quick guides, often just a couple of pages that you can easily access prescribing information, guides on HRT's type, progesterone doses, etc. There's a huge wealth of information there. We also have the NICE guidance, which is really helpful in terms of what we should be offering to our patients. As well as the British Menopause Society. Lots of information on those websites as well. I hope that's been useful. I hope it's been helpful for some of the basics of HRT and what we should be doing to support our women through this life stage. Thank you.